Hello and welcome to a secondary part on chapter 26, where we are going to continue to talk about alterations of cardiovascular function. So we'll pick back up at myocardial infarctions, and this is going to be an extended obstruction of myocardial blood supply causing myocyte necrosis. So essentially the coronary blood flow is interrupted and the cardiac muscle is not getting enough blood, enough oxygen. And there's two ways we can really classify myocardial infarctions. Pathologically, we can classify it as subendochondral or transmural infarction, and then clinically, we can classify this as STEMI or non-STEMI. And I'm going to just call this STEMI so it rolls off the tongue. And what STEMI stands for is going to be for the ST segment elevation myocardial infarction. So let's take a look at what our standard EKG in a healthy person looks like. You could see here's our QRS complex where we have ventricular contraction or systole, and then we are going to have our ventricular diastole. And so between the S and the T is that segment that we are interested in. So when we have STEMI taking place, that's where we're going to see that ST elevation. And we will continue to have coronary occlusion, and this is going to lead to a transmural infarction. What that means is that we are going to extend from the endocardium to the pericardium. So we could see that all along in here. And this is at the highest risk for serious complications. So we want to treat these patients quickly. With non-STEMI, we are going to see that there is an ST depression. And sometimes we may see a T inversion as well. The T wave will be inverted. And so in this case, we have persistent coronary occlusion that is leading to the infarction of the myocardium closest to the endocardium. So right within this area here. And so this is classified as our subendocardial infarction. So as this cardiac tissue is not getting enough blood flow or oxygenation, it is going to have the tissue within that surrounding area of the infarct undergo some structural changes. First is going to be the myocardial stunning. And what this means is that we have a temporary loss of that contractile function that is going to persist for hours or days after the perfusion has been restored. Hopefully we're recovering from this myocardial infarction in which we can do that. And this is really due to alterations that we have within the electrolyte pumps and the calcium homeostasis within the tissues. Our hibernating myocardium is going to be when this tissue is persistently ischemic and it undergoes these metabolic changes to prolong these myocytes' survival until the perfusion can fully be restored. And then we have myocardial remodeling. And this is a process that's interesting because it's mediated using angiotensin II, aldosterone, catecholamines, adenosine, and inflammatory cytokines. And it causes the myocytes, so imagine these myocytes over here, to go through hypertrophy. So we're going to increase these cells in size, and we have a loss of their contractile function that is actually far from the infarction site. Now, these are just the structural changes that we have, but of course we have some functional changes that take place, but it does depend on the size of the lesion and where the site of the infarction is. And that can include having decreased cardiac contractility and altered left ventricular compliance, a decrease within the stroke volume and ejection fraction, as well as increases in the left ventricular and diastolic pressure, and SA node malfunction. Now, many of you already know some of the clinical manifestations of an MI, but let's review them. We can have sudden severe chest pain, and this could be described as being really heavy and crushing, as if there's a truck sitting or an elephant sitting on my chest. And then we may have it even radiate to other areas, such as the neck, the jaw, the back, shoulder, or the left arm. And then we can also produce either nausea or vomiting, and this is really due to a reflex stimulation within the vomiting centers due to pain fibers being stimulated. And we have that vasovagal reflex that is going to affect the GI tract. We may also feel some diaphoresis. We can have peripheral vasoconstriction that can cause the skin to become cool and clammy, and we can have dyspnea. There may be some complications like a sudden cardiac arrest due to that ischemia or left ventricular dysfunction that can be observed through auscultation and hearing abnormal extra heart sounds, and also electrical instability. Now, if we were to do a 12-lead ECG, we can locate the affected area through identifying the changes within the ST segments and the T waves, kind of like we saw before with the STEMI and non-STEMI. So when we have our area that has been infarcted, we call that the zone of infarct and necrosis. And notice the light pink surrounding it. This is our zone of hypoxia injury. And this means that we can either recover from this and have our cardiac muscle cells return to normal, or we can have necrosis take place. And then we have in the white here the zone of ischemia, which luckily is reversible. Now you could see here the ECG where we have our normal P wave and our QRS complex and then the T wave. When we go through ischemia, you could see here that the T wave is inverted. If the tissue becomes injured, we have a change within our QRS complex and a disappearance of that T wave. And then here we can see an infarct where we have that severe drop within our Q, and then we continue with our S complex. Next, we're going to talk about some disorders of the heart wall, starting with some disorders of the pericardium. So when we have acute pericarditis, it means that we have an acute inflammation of our pericardium. And just as a reminder, we have this pericardium serving as an outer sac for our heart. And you could see the two layers of our pericardium over here. Now, this isn't labeled in the diagram, but this outer layer of pericardium has a fibrous layer and then a parietal layer. Then we have our pericardial space or cavity, and then our visceral pericardium, which is also known as the epicardium. So within acute pericarditis, it is going to be dry, or it could cause excessive fluid accumulation within this space. And that could be idiopathic, or it could be caused by a viral infection such as the flu or the measles or varicella viruses or even HIV. Other causes could be having a heart attack, any type of trauma, tumor, surgery, uremia, or a bacterial infection such as tuberculosis. Now, these layers can become inflamed and roughened, and as they rub against one another, we can develop a pericardial effusion, meaning we've got some type of fluid within this cavity here. So it could be serous, it could be blood, or it could be a mixture of both. And as that fluid starts to build up, we get a compression that starts to build upon the heart itself. So that cardiac compression is known as cardiac tamponade, which can equal or even exceed the diastolic pressure of the heart chambers. And so it's really going to interfere with atrial filling. So to treat this, we typically need to have a pericardiocentesis done, meaning we're going to aspirate the excessive pericardial fluid that we have within this cavity in order to take that pressure off of the heart. And we also want to treat the underlying condition if it's known in order to prevent it from happening again. Now, within constrictive pericarditis, this is when we're going to start to have some scarring and loss of elasticity that would prevent adequate cardiac filling during diastole as well. And this typically starts out as an acute episode, but then the fluid gradually will continue to build and cause the scarring and the thickening. And if this is to continue, we can have those visceral and parietal pericardial layers adhere to one another and we could get fusion of the two layers, which can create this fibrotic lesion that encases the heart in a rigid shell. And as you can imagine, it's going to then compress the heart and reduces the cardiac output of the heart. Next, let's move into disorders of the myocardium, and that of course is the heart muscle itself. So we call these cardiomyopathies, and the first one is going to be a dilated cardiomyopathy. So notice how these images on the right hand side are really only showing us the left ventricle and then the entrance to and out of the ventricle. So this entrance is going to be our mitral valve, this is going to be our aortic semilunar valve. So when we have dilated cardiomyopathy, develops from ischemic heart disease, valvular disease, diabetes, renal failure, alcohol or drug toxicity, or it could be due to peripartum complications or infection. And we typically do see this within cardiac failure though, and we get a dilation of either one ventricle or both ventricles. And this impairs the systolic function that can then increase the intracardiac volume. Getting this dilation, as we discussed, and the patient may have dyspnea, fatigue, and pedal edema. Next up, we have our hypertrophic cardiomyopathy. And this is characterized by this thickened hyperkinetic ventricular muscle mass. And it can be obstructive, which is one of the most commonly inherited genetic disorders of the heart. And we have a thickening of the interventricular septum. And the other major category of this type is hypertensive or valvular hypertrophic cardiomyopathy. And in this instance, we have increased resistance to ventricular ejection, which is usually seen in people that have hypertension or they have some type of valvular stenosis, and this tends to affect the aortic valve most commonly. And lastly, we have restrictive cardiomyopathy, and this is characterized by stiff fibrotic ventricles with impaired diastolic filling. So here our systolic function and wall thickness are normal, but the myocardium is becoming rigid and non-compliant. So these patients typically are suffering from right heart failure with systemic venous congestion. Let's venture into the disorders of the endocardium now. So over here we have the endocardium. It's the inner lining of the heart, and groups of disorders that we have here are valvular dysfunctions, mitral valve prolapse syndrome, acute rheumatic fever, and rheumatic heart disease, and infective endocarditis. So let's talk about each one of these, starting with the valvular dysfunction. So when we have a valvular stenosis, what we mean by that is that we have a narrowing of the valve. So we have a little opening and we get progressive obstruction to blood flow. And essentially it causes the heart to increase in workload so that the chambers are really trying to pump that blood through that narrow opening. Then when we have valvular regurgitation, or sometimes this is called an insufficiency or a incompetency, it means that we have impaired closure of the valve that allows that blood to move backward into the chamber above it or before it. And that increases the workload of the heart as well. So when we have aortic stenosis, which you could see pictured over here, and this is an actual picture of this condition, we get some calcium deposits on the cusps, and that is going to increase the afterload work of the left ventricle because it's trying to push that blood through into the aorta when it has this narrowed valve. So this is really known as a wear and tear type of disease as we age. Then we have mitral stenosis. So this of course takes place when we have our valve narrowed so that the blood flow from the left atrium is impaired and can't move into the left ventricle easily. And mitral stenosis is actually one of the most common forms of rheumatic heart disease, and we'll get into that in a few slides. So then we've got our aortic regurgitation, and we don't really have a picture of this, But here is our aortic valve, and so this valve would become incompetent and allow the blood to leak back from the aorta into the left ventricle. So these flaps are gonna go backward and that blood is gonna slide back. And so with this, during diastole, as this extra blood moves into the left ventricle, we're gonna have a increased afterload work of our left ventricle, and it's going to start to dilate and hypertrophy. And as a result of this increased pressure, we can have left ventricular failure. Then we've got mitral regurgitation, which is what this is an actual picture of. And we can see here that the valve is insufficient and allowing the blood to move back into the left ventricle, or sorry, the left atrium. And this is taking place during ventricular systole. So as those ventricles are contracting, and so from the pressure, that left atrium and ventricle are going to become dilated and hypertrophied. And it's doing this to maintain adequate cardiac output. So as that atrial myocardium starts to stretch out, we are going to start to experience atrial fibrillation, a quivering of these atria. And as that takes place, it increases the fluid back into the pulmonary veins and can cause pulmonary hypertension, which then can lead to failure of the right ventricle. And of course, because we said that the left ventricle is dilated and hypertrophied, we can have failure of the left ventricle as well. Lastly, we have tricuspid regurgitation, and so this is of course going to involve this tricuspid valve that sits between the right atrium and the right ventricle, and this is typically caused because of congenital defects or rheumatic heart disease or endocarditis, but it also could be related to pulmonary hypertension and dilation of the right ventricle, which pulls these leaflets, these cusps, apart from one another. And then we get volume overload in the right atrium and the right ventricle. And as that blood is pulling up, it then is going to move back into the superior vena cava, inferior vena cava, and cause increased systemic venous blood pressure. And eventually we are going to get right heart failure. Now let's talk a bit more about mitral valve prolapse syndrome. That means that of this mitral valve, either one or both cusps are going to billow upward into the left atrium during ventricular systole, so that contraction. And so mitral regurgitation can take place if that blood leaks into the atrium, which means sometimes we can hear this during cardiac auscultation, and it's going to be a regurgitant murmur or a mid-systolic click that is heard, and sometimes we can even see it on a ECG. Now, some of these patients can be asymptomatic, which it actually happens quite a bit in our population. It's the most common valve disorder and affects nearly 3% of adults, but some can have some vague symptoms, and that can include exertional dyspnea or fatigue due to a decrease in cardiac output. It can also cause palpitations or a atrial fibrillation. Again, the concern is maintaining the cardiac output because the valve is too floppy and the heart is working harder to get to its maintenance cardiac output. Shifting gears into rheumatic fever, this is going to be a systemic inflammatory disease that is caused by a delayed immune response to a pharyngeal infection by group A beta hemolytic streptococci. And this really is a febrile illness in which we're going to get inflammation of the joint, skin, our nervous system, and the heart. If it is untreated, it could cause rheumatic heart disease, in which we see that 10% of individuals actually develop who had rheumatic fever. And the primary lesion there is going to involve the endocardium. So we start to get inflammation of that endocardial lining and then swelling of the valve leaflets, which can become progressively adherent and start to stick to one another. And we can also get scarring and shortening over time, which of course is not going to allow the valves to function properly. This type of inflammation can even go and reach the myocardium, causing myocarditis, and we get fibrin deposits and are surrounded by areas of necrosis. So some common manifestations, of course, are going to include fever, as it's in the name, lymphadenopathy, arthalgia, nausea and vomiting, and abdominal pain, tachycardia, and epistaxis. And then our major clinical manifestations will include carditis, polyarthritis, chorea, which is, if you remember, is involuntary unpredictable muscle movements, erythema marginatum, which is going to be a reactive inflammatory erythema that we usually see due to this fever, and then subcutaneous nodules. Lastly, on this topic, we have infected endocarditis, which is just going to be an inflammation of the endocardium. And there are several agents that cause this to take place. And they're going to invade and colonize within those endocardial tissues. So those could be bacteria, viruses, fungi, rickettsia, and parasites. Now, the pathogenesis here can begin with damaged or prepared endocardium, meaning that there's been some type of endocardial damage due to trauma, or maybe there's a congenital heart disease or valvular heart disease, or we have prosthetic valves that affect the valves in the endocardium. And so what can happen is that because we have that damage in there, the endothelial basement membrane, which has collagen within it, is going to start to attract platelets. And that stimulates a sterile thrombus to form. Notice we said sterile because we haven't introduced any agents in yet. But when we do have some type of bacterial infection going on, it could be in the bloodstream due to injection of drug use or some kind of trauma. Maybe there's a dental procedure in which the gingiva have been manipulated, or it could be an indwelling catheter that has an infection going on, or it could even be a skin infection. In some form, that bacteria gets into the area of the endocardium and they start to adhere to that damaged area where we have that thrombus forming, and it does it through using adhesions. So then the bacteria, we're going to go into this phase now where the proliferation takes place. And the bacteria start to infiltrate the thrombus, and it accelerates fibrin formation and activates the clotting cascade. And although this could take place anywhere in the endocardium, usually we see it on the heart valves. And so we get what's called vegetations. And this means that we've got the growth of the microorganism there and the white blood cells enmeshed in fibrin deposits in the endocardium. So the classic findings here is going to be a fever, a new or changed cardiac murmur, petechial lesions on the skin, conjunctiva, and oral mucosa. And some characteristic physical findings are going to be these Osler nodes, which are these painful red nodules on the pads of our fingers and toes, or the Janeway lesions, which are not painful and are hemorrhagic lesions on the palms and soles of our feet. And other manifestations include weight loss, back pain, night sweats, and heart failure.